Hey friends, welcome to the next episode of the Musculoskeletal Minute in video form. Today I'm going to do a little sketch demonstration of my favorite ligament, the anterior cruciate ligament of the knee. And I'm going to review the basics of this ligament, including the anatomy, its function, common mechanism of injury and presentation, as well as what exam findings you should expect to see. And then a little bit about the workup of, and not going to delve too much into definitive treatment, but we'll just touch on that. So let's get started. All right, folks, so let's get started with the ACL. So the ACL, or Anterior Cruciate Ligament. So we'll start off by drawing our knee. Alright, so we have our femur, our tibia, our fibula, and our patella. So this is a left knee. And the anatomy of the ACL, the origin is inside the notch along the posterior lateral aspect of the femur. So it's going to be the posterior lateral aspect of the lateral femoral condyle, and it's going to run anterior medial and attach on the anterior medial tibia. So ACL. So if we're looking at that from the side, there's our femur, tibia and fibula, and our patella. The ACL will look like it's running from posterior to anterior. So just looking at the configuration and path of the ACL, you can deduce that its function is going to be limiting how much the tibia can go forward or anteriorly, or vice versa, how much the femur can go back posteriorly. So its functions are to prevent anterior tibial translation, and it also has some rotational stability properties. So once you know the function of the ACL and the anatomy, you can better understand the injury of the ACL, or the mechanisms of injury. So what are the mechanisms? Well, it is anything that causes the tibia to go too far forward with enough force to cause failure of the ACL. Now, in a realistic activity way, what that typically involves is a sudden stop or a change in direction. So we see that mostly within the sporting community, but you can have it outside of that as well. And within, it's usually a non-contact injury. It can be associated with contact, but most frequently non-contact. And it involves a sudden change in direction or stopping. And we'll frequently see patients. This occurs in sports such as basketball, soccer, football, skiing, and me personally, mine happened in baseball. So when it happens, how is this patient going to present? So they'll usually give the appropriate history of injury or mechanism of injury. So they had a mechanism of injury that fits the injury. And it involves a sudden change in direction or stop. Most frequently, patients will feel a pop. They will feel as if the knee gave way. Not too long after the injury occurs, there's usually a development of effusion, which they say the knee feels tight. As far as pain is concerned, if it's acute, more often than not there's a significant amount of pain, but if it's subacute, the pain generally settles down after a few days, so varying levels of pain. So we've got an appropriate history, and based on the history we're suspicious of ACL tear. So what exam findings would we expect to see if we are suspicious of an ACL tear? So from an inspection standpoint, it will likely have an effusion. From a palpation standpoint, you'll be able to palpate that effusion as well. They may or may not be tender to palpation. If they are, it's frequently lateral. And the reason for that is that the knee will frequently sublux anterior laterally, and when it realigns, it comes back forcefully, and the lateral femoral condyle and the lateral tibial plateau will collide, and that creates bone edema, and that is painful and can be elicited on exam. Range of motion may or may not be affected, but if they have a large effusion, they may have limited flexion. And now here is where the money is from an exam standpoint. The gold standard special test on physical exam is the Lachman, and the other tests are the anterior drawer, which is much technically easier to perform but less sensitive as well. And then finally you have the pivot shift, which is quite sensitive, but it is much more technically difficult to perform. The patient has to be perfectly relaxed, and it requires a bit of skill on the evaluator standpoint. So those are our exam findings. How are we going to image this? Can you image the ACL? Well, you can image the ACL, but that's not something that's typically done in an immediate visit. Should we get x-rays? Absolutely, you should get x-rays. So let's say ACL imaging. Plain x-ray. So you get an x-ray for a couple of reasons. The main one is to rule out fracture. All right. Secondarily, you may see findings that can give you a clue about the ACL, specifically something called a Segond Fracture. Now, what a Segond Fracture is, let's draw our tibia. Our tibia, fibula. So a Segond fracture is a small avulsion off of the lateral tibial condyle. And what that indicates is that you've had an ACL tear, and that translation of the tibia anteriorly has caused the capsule to avulse a small piece of bone off the lateral tibia. So you can see that on an x-ray in some cases. And if you see that, that generally is pathognomonic of an ACL tear. So a little Segond fracture, anterior lateral aspect of the tibia. But the definitive diagnosis of ACL tear is done by means of MRI. So we have our MRI and it's positive. That's, like I said, that's the definitive test, and you can proceed with definitive treatment after that. But before we get to that point, and this is really the main reason why I'm doing these, is for our ER, urgent care, PCP, and sideline evaluation and treatment. So the evaluation is all the same to this point, but the initial treatment in these settings, first thing is you're treating the symptoms with RICE. Okay, rest, ice, compression, elevation. You want to, secondly, you want to protect the knee. You don't want any recurring instability or subluxation episodes due to the risk of furthering injury, not necessarily of the ACL, but potentially damaging the meniscus or other ligamentous structures, or most importantly, the articular cartilage. So you want to protect. Ideally, you want to put someone in a telescoping range of motion brace, or TROM. They're going to use that throughout their treatment course. If you don't have that available, an immobilizer is fine, but not, again, ideal. The other option is just simply use crutches and have them non-weight bearing. And as far as crutches go and weight bearing, they can be allowed to weight bear once fracture is ruled out. And that would be to tolerance. Next, fourthly, NSAIDs and non-opioid pain management. And finally, referral to ortho. And referral to ortho can be done with or without the MRI. If you have the capabilities of getting the MRI beforehand, that's great. It speeds up the treatment plan. But if you don't have access to MRI, if you're working in an ER urgent care setting, then it's certainly reasonable to send them out without the MRI. But if you are in a PCP, primary care setting, and you want to get that MRI, it's certainly appropriate. So definitive management for ACL tears, I'm not going to delve too much into that because that can be multiple talks in itself. But the things that I want you to know as far as the basics go is, number one, ACL tears do not heal. Secondly, definitive treatment, you have conservative and surgical options, and for most people, the surgical option is going to be best, especially if they're younger and active. If someone is sedentary, doesn't have a physically demanding job, it's possible to get by without surgical reconstruction, but that definitive management is typically requires graft reconstruction, and those grafts can be either autograft, where it's the patient's own tissue, either patella or hamstring graft, or the two main ones. There are others, or they can have an allograft, and again, I'm not going to get too much into that. But that concludes this session on the basics of the anterior cruciate ligament. I hope you have found it useful and beneficial, and that you can carry this into your practice and use it the next time you see someone you suspect may have an ACL tear. So again, thank you very much, and we'll see you next time.